Thanks so much, everyone, for having me. My name is Sarah Mixer. I'm an assistant professor of internal medicine and pediatrics at Hopkins. And I'm going to be talking today. I was invited to talk about clinical reasoning. So the title that was given to my talk is How Good Clinicians Think, but I have kind of surtitled it Foundations of Clinical Reasoning. So the idea behind the talk is just to kind of think about how we build clinical reasoning through our careers and especially through training, and then think about some strategies to help you guys build that. I know you guys are at different stages. We have students, first, second, third, and I don't even know if we have any fourth years. So I think also you guys are going to be at different levels with this too. So hopefully there's something to take away for everybody. So I wanted to kind of ground us in a case. This is taken from a New England Journal article on clinical reasoning that was published in 2006. So this is an example of how two different learners or two different clinicians might reason through a case. And here it's listed as novice resident and expert resident, but I think we could think of it as really like early learner, later learner, or more expert learner as well. All right, so the patient story, this is happening in clinic. The patient story is that my knee hurt me so much last night, I woke up from sleep. It was fine when I went to bed. Now it's swollen. It's the worst pain I've ever had. I've had problems like this before in the same knee, once 9 months ago and once 2 years ago. It doesn't bother me between times. So I think in our imagined situation, both these learners or residents, clinicians have gone into the room and talked to the patient, and they're going to come out and present to their preceptor. And the novice learner says, my next patient is a 54-year-old white man with knee pain. It started last night. He does not report knee trauma. On examination, his vital signs are normal. His knee is swollen, red, and tender to touch. It hurts him a lot when I test his range of motion. He's had this problem twice before. Whereas the more expert learner, more expert clinician says, my next patient is a 54-year-old white man with a sudden onset of pain in his right knee that awakened him from sleep. He does not report any trauma, and it was essentially asymptomatic when he went to bed. His history is remarkable for 2 episodes of similar severe pain 9 months and 2 years ago. He is pain-free between episodes. He is afebrile today, and his knee is swollen, tender to touch, and erythematous. So I think kind of comparing and contrasting these two presentations, I think you see a few things. First, I think this novice learner is more in that like reporter algorithm, if you guys use that RHYME algorithm in your training, where they're really just getting information and kind of regurgitating it with minimal processing back, whereas the expert learner is more doing interpretation, highlighting salient points. Even some of their language is a little bit more sophisticated. So instead of saying the knee is red, they're saying the knee is erythematous. So then the teacher asked both residents, what do you think is causing this patient's knee pain? The novice resident says it could be an infection, it could be a new onset of rheumatoid arthritis, it could be Lyme disease. Since he doesn't recall falling, I doubt it's an injury. I don't know whether osteoarthritis ever presents like this, but he does have a history of knee pain. So a pretty broad differential, ruling out some things like injury, but not really providing much of their reasoning, how they're going to think about these different diagnoses. Whereas the expert learner says the patient has acute gout, so like putting their dollar down. He has had multiple discrete episodes with abrupt onset of extremely severe pain involving a single joint with evidence of inflammation on examination. Before all his episodes, he is asymptomatic. I would have expected gout to affect the first metatarsal phalangeal joint, but it can present in the knee. Nothing suggests any ongoing chronic problem in the knee. I don't see any portal of entry to suggest acute infectious arthritis, and he looks quite well for that. His other joints are normal on examination. I doubt that he has a flare-up of osteoarthritis with pseudogout or a systemic inflammatory arthritis such as rheumatoid arthritis. So, right, much more articulated. They've selected a diagnosis. They've shown some of the reasoning that brought them to that diagnosis, and then they've listed a few other diagnoses that they considered, and then briefly shown their reasoning of why they didn't pick those. So how do you get from like point A to point B as a learner, a clinician, a student? And that is your clinical reasoning. And so the point here today is to make clinical reasoning more transparent. We could spend hours and hours and hours, whole careers talking about this, but today I'm just going to highlight a few core principles that folks who study how we think about problems have kind of brought to the fore over the past kind of 20, 30 years of growth of scholarship in this area. And so the three core principles I want to cover are problem representation, illness scripts, and dual process theory, which is also known as fast and slow thinking. And here in this diagram on the side is just kind of a thought about how all that comes together, right? Your knowledge, context, and experience is the framework, or kind of the bubble in which you take the patient's story, more data you acquire, how you think about the case, your clinical reasoning, and arrive on a diagnosis. A lot of what I am talking about here comes from this article in the New England Journal by Bowen in 2006. And then there's also, when the slides look a little bit different from this template, those are from a series of clinical reasoning presentations that are available for teachers and students and anybody from the Journal of General Internal Medicine about clinical reasoning. So let's start with problem representation. So the problem representation is a one-sentence summary highlighting the defining features of a case, which helps clinicians generate a differential. And so when we think about that, there's three main questions we want to ask. One, who is the patient? So what are the pertinent demographic factors, risk factors that might make them vulnerable to different disease processes? Then what's the temporal pattern of the illness? What's its duration? Is it extremely hyperacute? Is it acute, subacute, chronic? And what's the tempo? Is this one that's stable, progressive, waxing and waning, intermittent? And finally, what's the clinical syndrome? So that's the key signs and symptoms. Sometimes we have a word to tie all those things together, like you might say, like hypotension, tachycardia, fever. A source of infection we might call sepsis, right? For example, or we might just be kind of calling in like the core descriptors that are most salient. So let's take an example. You see a middle-aged man with acute onset pleuritic chest pain, shortness of breath, and hemoptysis after a total knee replacement. For some of us, this might already be calling up a specific diagnosis, but let's kind of tease out the elements of the problem representation from this one-liner. So that is his pertinent demographics and risk factors. So he's a middle-aged man who's recently had a total knee replacement. This is acute onset for our length of tempo. And what are those key signs and symptoms? Pleuritic chest pain, shortness of breath, and hemoptysis. Again, you might already be thinking of a very specific clinical problem that this is, and we'll come back to that a little bit later. So here's an example of an HPI. In the original problem representation presentation, they really spend the whole time kind of talking through this and delving into the problem representation here. But for us, I'd like us to really use this to practice our skills. So get ready to make a problem representation based on this HPI. A 43-year-old Mexican woman presented to the emergency department with 1 week of abdominal pain, fevers to 38.9, intermittent frontal headache, and 2 days of left upper quadrant pain. The pain was sharp, constant, and radiating to the mid-epigastrium, right upper quadrant, and left flank. She had episodic nausea and vomiting. She had no change in her pain with eating, no hematemesis, dysuria, or diarrhea, and no photophobia or other neurologic symptoms, and she's not sexually active. So I want everybody just to take like 30 seconds and think about how you would kind of make your one-liner for this case. It might be a short 30 seconds. All right, we'll assume everybody kind of has something in their mind. All right, so here are two examples of how you might make a problem representation or one-liner for this case. So one is a 43-year-old woman with fever, headache, and associated upper quadrant abdominal pain and nausea and vomiting. Or you might say a 43-year-old woman with acute onset of sharp left upper quadrant pain, nausea, vomiting, and associated headache. And I think this shows in some ways like the power of the problem representation in guiding your thinking. So if you are really more focused on her fever and headache, these like more neurologic signs, a CNS pathology becomes your primary concern. Whereas if you prioritize the abdominal pain, nausea, vomiting, right, then the GI pathology is a primary concern. So even from how you put together and phrase your problem representation, you're already starting to point yourself in a direction or kind of show us how your thinking is going. So let's return here to our case. And again, I think we see like the difference in the problem representation a little bit between our novice and our expert in kind of naming the clinical syndrome and pulling out the salient points. And we know that our expert resident is pointing towards gout. So here's a sample problem representation, kind of a little bit more in line with the expert learner, which is this is acute onset of a recurrent, painful monoarticular process in an otherwise healthy middle-aged man. So our demographics and risk factors, it's a middle-aged man, length, tempo, it's acute but recurrent, right, which is important for this problem. And then key signs and symptoms, this is painful, it's not just a swollen joint, it also hurts, and it's monoarticular. So once you have a problem representation, you really have the ability to start mapping that onto diagnoses. So here's an example from this case, right? You have your problem representation at the core, and then this experienced learner, right, they kind of talk you through it. They are mapping that problem representation onto these different problems. So here in gout, right, episodic, recurrent, male sex, chronic, monoarticular. It's really all these discriminating features and defining features are helping us end up on the diagnosis of gout. There's some discriminating features in the other diagnoses she was entertaining, like osteoarthritis, that don't fit. Multiple joints, long-term process for osteoarthritis, and then infection, a single episode of a febrile patient. So again, once you have a really well-articulated your problem representation, you start to try to fit it into different problems or illnesses. And one way you do that is with illness scripts. So an illness script is a structured mental summary of a provider's knowledge about a specific disease. Illness scripts are unique to individual clinicians. So my illness script for pulmonary embolism might be different from Dr. Gulati's illness script for a pulmonary embolism, though I bet they're pretty similar, but just based on the patients we've seen, the patients we routinely take care of, our experience as a clinician. But there are three main categories that are generally included. These are the risk factors for the disease, the pathophysiology, and the clinical characteristics. So when we think about clinical characteristics, what are the important things we're thinking about? Time course, characteristic symptoms and signs, typical clinical course. Is this something where people get really sick or it's pretty benign? What are the diagnostics involved? And what's the treatment? So let's do an example with community-acquired pneumonia. So what's the pathophysiology? It's infection of the lower respiratory tract. Epidemiology, more common in folks who are older and folks who have structural lung disease. The symptoms and signs, fever, cough, shortness of breath, happening for several days, but typically less than 1 week. What do you see in your diagnostics? You might see leukocytosis or an infiltrate on a chest x-ray to support the diagnosis, but as we always say, pneumonia is a clinical diagnosis. And what do you treat with? You treat it with antibiotics. So this is like a concise and structured way that I can store the knowledge that I have about community-acquired pneumonia and then be able to access it relatively quickly when I'm trying to map it onto my problem representation for a patient. And when you're learning and kind of building these about problems, it can also help you think about where the gaps in your knowledge are, right? Like if you're thinking about community-acquired pneumonia and you don't know what the treatment would be, right? You kind of can easily say, you know, that's a hole, or you know something about the epidemiology, but you want to know more. And the other thing I think is important is this can change over time, right? As you see more patients, as you learn more, these can grow, they can contract, and you can kind of begin to, or continue pulling out the most important tips. All right. So let's go back to our case. And here's our novice resident's response to the question of what do you think is going on? And it's just really like a differential diagnosis that actually doesn't even include the actual diagnosis we think the patient has. And so I think this reflects that a couple things. First, I don't think that this learner, right, has very articulated illness scripts for most of these problems. They're just naming diagnoses. And it seems like they might not even have an illness script for gout. So when they were thinking about the presentation and trying to match it onto potential problems, it seems like gout wasn't even on their radar. When we look at the more experienced learner, again, like they have rapidly mapped this onto their illness script for gout. And then they talk about what fits with the illness script, what fits a little bit less, but overwhelmingly for them, the evidence is that this is gout. And then references a couple other problems and maybe, again, mapping the problem representation onto their illness script for those other problems like osteoarthritis or inflammatory arthritis. So this might be the illness script they're using, right? Predisposing conditions for gout, age over 40, male sex, using alcohol or diuretics. Thinking about pathophysiology, it's abnormal uric acid metabolism, crystals precipitate in the joint and you have inflammation. And so what happens? You have acute pain. It's usually a single joint and can be the first metatarsal phalangeal joint, the big toe, and then it's recurrent. So again, this student, or this learner, resident, whoever, has a well-defined illness script for gout that they were able to map this problem representation onto. So the last piece is dual process theory. And that's the idea that there's two different ways that we think about problems and incorporate information. The first is system one, helpful in dual process systems that have one and two. System one is intuitive, quick, reflexive. It's dependent on pattern recognition. So an example might be you have a patient who's recently treated with antibiotics who presents with diarrhea, abdominal pain, and leukocytosis. And have everybody unmute themselves and shout out the answer, but I think many of us have already made an association. C. diff colitis, right? You have diarrhea, leukocytosis, antibiotic use. That's kind of the first thing that comes to your mind. And there's other examples, right? When we had the problem representation of the man who had recently had a knee replacement and had pleuritic chest pain, shortness of breath, and hemoptysis, right? My system one processing clicked right away. Oh, that sounds like a pulmonary embolism. I got to rule that out. So that's your kind of fast thinking. But that's not always practical. So, and that's why we have system two, which is slow, analytical, and deliberate. So this is most commonly used when you have a patient with a much less defined or perhaps more complex problem. It's also what you're using more frequently when you have, less experience, right? And less ability to do that pattern recognition. Like if you had never learned about the association with antibiotics with C. diff diarrhea, you might hear about that patient with acute onset diarrhea and you wouldn't have access to that kind of rapid recognition. So another example of a time we might use like a system two analytical process is a patient who has chronic diarrhea with abdominal pain and leukocytosis, but no other risk factors. Because this differential diagnosis is going to be really broad, right? It could be community-acquired C. diff without any triggers. It could be inflammatory bowel disease or another non-infectious inflammatory cause. It could be a malignancy, malabsorption. It could be a really broad diagnosis. And so in real life, clinicians alternate between system one and system two. And so this is why we call it like dual process, because you're using both of them. So for example, like let's say you had a patient come in, she's an obese middle-aged woman and she comes in with right upper quadrant pain that's colicky in nature. So if I hear that, right, I don't know if you guys have heard like the 4 F's, right? This is like a very stereotypical, typical place where you'd be concerned about gallbladder pathology or cholecystitis. But let's say you get an ultrasound and it shows that the patient doesn't have cholecystitis. So then you started in system two processing, reflexive. I see a pattern, I have a leading diagnosis, but that diagnosis is ruled out. Then you need to step back and go into your system two analytical reasoning, where we got to broaden our differential diagnosis and consider other things. And right, there's pros and cons of both, right? System one processing is quicker. It uses your knowledge and your experience. But it can sometimes lock you in too early on a diagnosis. It can really fall into your biases of what you've seen recently. Whereas system two is much more time consuming, right? But perhaps it's going to be more thorough in some situations and help you incorporate more data to get to your diagnosis. So we're back to our case. To say, guess who's back? It's our case. And in here, let's look at this again related to these issues, right? So I think that when you look at this novice resident's list of diagnoses, it's pretty clear that they're doing like system two processing, right? They say it could be an infection, it could be a new onset rheumatoid arthritis, Lyme disease, probably not an injury, maybe it's osteoarthritis, but he doesn't have a history of knee pain. So, right, it is very broad, and they're going to be having to kind of go through each of those individual diagnoses to come up with what they think is actually going on. Whereas resident 2, she has recognized this pattern probably based on her problem representation, middle-aged guy, uniarticular acute pain that's recurrent. She says, that's gout. I know it when I see it, like my Aunt Minnie, as they say in radiology. And so she really has that recognition. But you can see, even though she made that immediate diagnosis, she does a little bit of system 2 processing by saying, okay, here's what I think is going on, but what are some other things I could consider? And so she brings up a couple other possible diagnoses, but then goes through her reasoning as to why those are not the most common or most likely explanations. So again, I think in this example, you see these 2 learners or 2 clinicians kind of, and how they are using or not using the principles of problem representation, illness scripts, and then their processing styles to arrive at a diagnosis. So once we've been through all these things, kind of what next? How can you build this as a learner? So I have a couple tips, a couple things that I recommend to learners I'm working with and learners at all levels, right? I think that, I know things are different now with COVID, but even in, the first and second years, you do have some exposure to patients, whether it's, times you might be in clinic or patients who are coming in or speaking to your classes. So when you see a patient, really work on practicing your problem representation. So don't fall back on the one-liner that might already be in the chart for the patient. Really kind of say, in the context of this presentation, this problem, how am I going to summarize what's going on with my patient? And so just get into the habit of doing that kind of as a mental exercise, or if you're being expected to present the patient, obviously, then it's very important to build that. I think another thing that can be really helpful is when you're learning about problems and clinical syndromes, whether it's in class or especially when it's from patients, build illness scripts for those problems. So, if you're meeting a patient in a clinical session that has, cellulitis, right? Build your illness script for cellulitis based on what you saw in that patient, but also don't limit yourself to kind of only learning about that one problem from the patient, right? Like if the patient came in because they had unilateral lower extremity swelling and redness, and you decided they had cellulitis, great, you've learned a lot about cellulitis and you learned how it happens and what the signs and symptoms are and how you treat it. But what else was on your differential, right? Like build your illness script for deep vein thrombosis. So how is that different? And then how would you be distinguishing between the 2 diagnoses? So really thinking about patients and their problems in terms of the different things that might be causing them. And not limiting yourself into only learning about the diagnosis the patient actually has. And then I think another piece, and I'll get into some specifics on the next slide, are employing some learning resources that focus on clinical reasoning. So I should have stock in this book. I don't. I've never met the people who wrote it. I don't have any money invested in McGraw-Hill or Lang or whatever. But this is my favorite textbook for clinical reasoning. It's called Symptom to Diagnosis, an Evidence-Based Guide by Stein, Sifu, and Alcorn. And the way this book works, and it's a little bit more pertinent, I would say, kind of in your clinical years, to give that preface, but the way it works is it goes through problems. So it'll say, I have a chapter on shortness of breath, a chapter on dizziness, a chapter on chest pain, et cetera, et cetera. So like 40 problems. And for each of them, it'll have like 4 different cases. And for each case, it's going to go through a differential diagnosis. It's going to build the problem representation for the patient. It's going to talk about the different potential differential diagnoses. And it's also really based in evidence-based medicine too. So it will go through the positive and negative predictive value of different physical exam findings, of history findings. And again, it's really encouraging you to build illness scripts within each of those problems. So I think it's a really fantastic resource. There are other textbooks that are also great for clinical reasoning, but this is my favorite. I know at Hopkins we have it available electronically through our library, so that might be true at your school as well, but it is also something that is available obviously wherever you buy your books. There's a couple of podcasts, so not to be a symptom diagnosis stan, but they have relatively recently put out a podcast that really, again, like goes through symptoms and the clinical reasoning around them. It's similarly themed by problem. And I think they have like 8 or 9 episodes out, and that's on wherever you get your podcasts. Another great clinical reasoning podcast that is also based in internal medicine is the Clinical Problem Solvers. And then the Curbsiders is another prominent internal medicine podcast. They have a great episode on clinical reasoning and kind of becoming an expert in episode 90 with a kind of expert clinician at UCSF who's a real leader in clinical reasoning and teaching. Another thing that's fun and kind of turns into a little bit more of a game is the Human Diagnosis Project, which is an app that users submit cases to, and it kind of guides you through, different levels of information reveal, and you're kind of listing differential diagnoses as the case gives you more information, and you can say, okay, now that I got this more information, I'm taking this diagnosis down, or I'm adding a new diagnosis. And so that, again, that kind of gamifies the process a little bit, which some people find fun. So, and again, this is a really limited, these are some of the resources I have found helpful. So just a couple references. Again, I drew heavily on the Journal of General Internal Medicine's Exercises in Clinical Reasoning program that's online, and this article by Judith Bowen. So I think we have a few minutes. If anybody has any questions, I'm going to change my view so I can actually see people.
Thanks, Dr. Mix. That was a great talk. Great. Any questions?
Dr. Mixter, my name is Mary. I'm a third-year medical student at University of Maryland. I use the Human Diagnosis Project app, and it's fun, and it has a good phone interface to use. But my question is, so I think students primarily use, we have 2 different kind of learning during the clerkship years, one's for, and one is for clinical practice. Yeah. What are your thoughts on how to potentially bridge the 2 in studying, for in limited time in these core rotations? What are your thoughts? Using UWorld to study for something clinical, or maybe that's not really, it's those are foundational knowledge.
Yeah. I think that's a fantastic question, Mary, and that's something that I work with our clerkship students in medicine at Hopkins. It's something that a lot of people struggle with, because I think, unfortunately, there's definitely overlap, but I think you kind of hit the nail on the head, right? A lot of these questions, that the kind of board style review questions, sometimes there's a fair bit of clinical reasoning embedded in them, but a lot of it is more, let's say, system 1 processing, right? Pattern recognition. And so I would say it really is kind of striking a balance. I think that most of us, if we're going to be tested in a multiple choice test, right, we have to do some of that type of review. But so what I recommend to students is, set some time aside for that, have an app that you can do in downtime and where you're really practicing questions and maybe some blocks. But when you're really learning about your patients, instead of relying something on up to date, where you might end up really reading very in depth on the specific problem your patient has, you're going to learn everything about acute intermittent porphyria, right? Instead of kind of really going down that rabbit hole, or maybe in addition, take a step back and say, okay, well, what was the problem that got us to this diagnosis, right? Let's say it was intermittent severe abdominal pain. So then take a couple other diagnoses that you could have made for that patient and kind of compare and contrast, build those illness scripts. So I think the place to build that clinical reasoning skill is by enhancing your kind of patient specific learning and kind of taking a step back and broadening that. Because I think it's disingenuous for me to be you can learn everything you need to know from just, thinking about reading broadly, because I think most of us, again, if we're going to be tested in a multiple choice environment, need to do some of that practice. So I kind of recommend students expand their thinking about their individual patients to think about more diagnoses to build those illness scripts.